treated. They might be blocking their airway or closing their eye or something, and they get all kinds of innovative treatments to deal with these. She had one in her eyelid here. It's in her forehead, and it's in the process of a regression under treatment on the picture on the left. She did very well until she was 18. She's an avid mountain climber. She was up at 10,000 feet and became paralyzed on one side. They brought her down from the mountain. She got her strength back. And then the diagnosis of moya moya was made. And here's the question of this stress being induced by this mild reduction in oxygen at that level. So sort of a proof of principle in the discussion that Carrie had earlier today. So other additional findings in this series, we have familial cases, 12 families, 19 with a parent-sibling or a family relationship. Relatively uncommon when you think about it in this overall series. And I mentioned the leukemia survivors, identical twins. I just learned of another pair of identical twins here today, but it's interesting to me now, this would be 4 sets of identical twins with only one of the twins having the moya moya. So that implies that there's a genetic component here, but there also has to be something else happening environmentally that causes this process to get turned on, and we don't know what that is. We have one identical twin who has an affected child, an affected sibling, who are here today, and but it's interesting, I also have an adult set of identical twins, and one twin doesn't have it. So it's a very interesting thing to ponder about what's going on here. And another interesting phenomenon, I hesitate to bring this up, but this is, we have 2 children who we've been following who have developed brain tumors in the follow-up period. May be related to growth factors in the brain that are somehow turning on a gene that's responsible for the development of brain tumors. This is pretty rare, and I don't want to cite this as a public health problem and have you all worry about this, but it's an interesting phenomenon. And as you can see, 50% of our children don't have any associated condition at all. So it's a totally idiopathic. Nobody knows what causes it. So in this whole series, there's 611 operations. So we've had 49 patients with unilateral surgery only. Gary's figures are pretty much the same as ours. If a patient has unilateral disease and there's nothing on the other side at all on the angiogram, those patients don't progress. If they do have some mild abnormality on the other side, what is our figurehead is about 2/3%?
Yeah, 2/3 over a 5-year window.
Over a 5-year window are going to progress. So we pay a lot of attention to those findings on the arteriograms. So again, when I give this talk to docs, I talk to them about how careful the anesthesia has to be. And when I talk to patients, when they're going to have surgery done somewhere else, I tell them, you make sure that the anesthesia people know what they're doing in terms of management here, because a number of children have their first stroke when they're having anesthesia for something else, an appendix, a fracture that's being repaired, a urological operation. I've just seen this time after time after time. So the anesthesia is a real stressor here, and the anesthesia has to be managed differently than most people manage anesthesia. These kids have to be kept hydrated, as was mentioned again earlier today. The doctor can't hyperventilate the patient when the anesthesia is done. The blood pressure has to be kept up. You know, as neurosurgeons, we're operating on a patient with a brain tumor. We dry our patients out. We don't want much fluid in the brain. We hyperventilate them because that shrinks the brain and makes our surgery easier. So everything we do for a normal brain tumor patient is dangerous for a patient with moya moya. So I mentioned we use intraoperative EEG during the surgery. The EEG technician is there monitoring everything we do. If there's a little blip or something goes wrong with the EEG, we try to adjust the blood pressure or change the carbon dioxide levels in the blood, or give the patient a medicine to reduce brain metabolism and so on. And I mentioned we try to get both sides operated on the same anesthetic. Here's our follow-up regimen. And we keep the patients hydrated during the first 48 hours after surgery. Those of you who've been in Boston know this routine. The kids are on IVs for a couple of days with a lot of fluid being given to them. We start the patients on aspirin as soon as we know about the diagnosis. So they come in the office, they come with their films, aspirin right away, and we keep the children on aspirin right through the surgery, and then again, as I mentioned, hopefully lifelong. And we'll get an MRI in 6 months, and then thereafter, in a year, we get angiograms. Now, I've gone through several stages about this. Gary, you mentioned your regimen here. For a while, we got arteriograms on everybody a year later because I wanted to make sure the operation was effective. We saw how effective it was, and then I began to think, bringing the patients back in, getting that study done, the expense and the inconvenience and so on, and we stopped for a year or two, and now I'm back doing it again because I think the information that's gleaned from that study is extremely important, particularly if the patient years down the road has a problem. You want to know what was going on then, how successful the surgery was, and if their condition, if the patient has symptoms, what are these symptoms due to? So I think that postoperative arteriogram is important, and we're certainly back to doing it on that one time a year after the surgery. I don't repeat it ever again unless there's a clinical indication for it. But we do get yearly MRI, MRA studies, at least for a couple of years until I'm sure everything is stable, and then we gradually reduce the frequency of the follow-up. The thing about reducing the frequency of the follow-up, I don't ever want to lose contact with my patients, and that MRI is a nice way of tethering the patients to our practice so we know what's going on and we can follow them. Because when you come to a group like this, what do you all want to know? You want to know what's going to happen to me in the rest of my life. Am I going to have problems down the road? And this is how we learn about this. If you think about the history of moya moya, that Gary mentioned the disease was diagnosed in Japan in the 60s. It was really the first surgeries that I did in Boston was in the 80s. I mean, that follow-up is very limited, and how valuable it is. I mean, it's like a jewel to have that information from you all about how things are progressing and how you all are doing in your lives. So we get the MRAs, you can see the follow-up, you can see the collateral on an early MRA. It's certainly by 3 to 6 months there's something there. And I mentioned the angiograms. And Gary showed angiograms after his indirect operation, after his direct operation. It's interesting to me that this same enlargement of that superficial temporal artery goes on in this indirect procedure too, and it's the brain just starved for new blood vessels that widens these things out. Here's an artery picture, here's an arteriogram, and see the arrow here is on this teeny little blood vessel here that we used as the donor vessel for the surgery. And if you look at the year, 1 year post-operatively, here's that blood vessel here now, and it's dilated up, and you can see it on this early stage of the arteriogram 1 year after surgery, that it's all these black things here are the new blood vessels getting to the brain, and on the later picture you can see the whole side of the brain filled by the blood vessels from this injection into that external vessel. And here's another study. Gary has saw these, as we just showed these in the webinar, but this arrow is on another teeny scalp vessel here in one of these youngsters. And here's the 1 year post-operatively, here's that artery. Again, like Gary said, it dilated up almost to the size of a native carotid artery, and the later film shows again the whole brain being filled by the injection there into that blood vessel. It's really a very remarkable phenomenon that takes place in these patients. So one of the questions I've been asked, how much time do I have, DJ?
As much as you want, sir.
No, I just want. Don't say that.
About 15 minutes, sir.
All right, that's great. One of the questions that the patients ask is, well, how about these blood vessels over the surface of the brain that you've been put in by surgery? Are they going to last? And are they going to shrivel up just like the moya moya blood vessels do? And the answer here is that they don't shrivel, that they last and they get bigger and bigger, and Gary has talked about this in his talk. I have very few actually arterial examples of this because thankfully we don't have to study the children again. But this is a child who we had to study again. This is one of the kids who developed a brain tumor And we had to do a repeat arteriogram on this child to see where we could safely make our opening in the scalp and not disturb the blood vessels that were already there. We couldn't make our incision, for example, over an area where new blood vessels had grown into the brain that would cause the patient to have a stroke. So this is the arteriogram that was done after, 1 year after the surgery that was done in 1988 on this patient. And here's the 1 year post-op arteriogram, and all the blood vessels you see here are coming from the synangiosis. And here is her arteriogram done in 1997, just prior to the surgery. And you can see that the blood vessels that were there on the left side are there on the right side, and they're even more profuse than they were on the initial study. So those blood vessels have lasted and done quite well. Her tumor was a benign tumor. Here she is with her parents last year. And she's done very well too. So, in terms of the long term here, are the patients, once this operation is done, are the patients going to have another stroke? And what are the chances that's going to happen? And when we looked at this and we published our first series in neurosurgery, in the journal Neurosurgery, and that was earlier in I think 2004 that paper was. And this is, each one of these lines that runs across this is one single patient. The surgical date is the middle of the graph here. And then the line to the right represents the number of years the patients have been followed since the surgery. And these are all patients who presented just with strokes. We use this as an endpoint because it was absolute. There was no question as to whether there was really something that happened or not. And you can see that all the events on this table are